Welcome, everyone. Hi, my name is Ariella, Dr. Ariella OFRAN, and I'm from Clalit Health Services. I live in the north of the country, and currently as you know, we're all in difficult times. Besides we're 9 million, but we're a small community. Everybody knows everybody. So each house has someone that he knows that was hurt. So it's a difficult time, but I think it's very important that we talk together at these times. I prepared this lectures about 3-4 weeks ago, and I can confess that I didn't have a minute to go over it. The last few days, we're overloaded with work with evacuees that have moved from the south to the area where I manage, and also from the northern part of the country to the area of Tiberias. So we're all in that, but I will try to put it aside now, but I'm noting it because even if you have questions regarding that, I will be open to questions also later on. I am going to talk about I'm a family doctor, and I have an MPH, a Master in Public Health from Tufts University in Boston. And I practice medicine as a primary care physician, and I manage a large area in Clalit Health Services that is the largest health fund, HMO, in Israel. I will start to talk about, I was asked to talk about the healthcare system. And since I'm a teacher in nature, and I teach also in different scenarios, I teach things related to medicine, I will start with some basic knowledge regarding it, also because not only because I'm a teacher in nature, but because I think that when you come to understand the Israeli health system, it's important to talk about few fundamental things of description of a system in order to understand what is happening here and how is it different from where you come from, or maybe it's not different, but it will help. I think it helps to understand the differences and the similarities and to prepare yourself. Another thing, just to let you know, my English is relatively good because as a child I was in the United States, but also as a mother with 4 children, as a physician. So I have met different systems, and not only that, I have moved my family with 4 children to the United States for 2.5 years and acclimated them back. So some of the experience I know, but only some, because when I went to the States, I knew that I'm coming back to Israel. But throughout my work in the last 20 years, I have worked with many immigrants and tried to help acclimate and to bridge the gaps as people were starting their work and their understanding of the system here. So I am very glad for this opportunity. So if we talk about health, usually we're a health system. So the basic question is, what is health? And there are a lot of descriptions, but if we'll go to the WHO, it defined it as a complete state of physical, mental, and social well-being, and not only the absence of disease. And when defining a healthcare system, it defined it as all the activities whose primary purpose is to promote, restore, or maintain health. The health system as of today is much more complex than the classic doctor of 200, 300, 500 years ago, because we do not get a patient that comes in and we just try to deal with limited abilities with some acute problem that they brought into the room. We have first, they come to us, we go to them. We treat them electronically, And we treat acute care. Since we treat so well and we have so much abilities, we treat also a lot. We have to deal a lot with chronic care, because we can treat the acute diseases and leave people alive for much longer and deal with chronic diseases for much longer. And accordingly, that is part of the health system. A basic part of the health system is the preventive care. If once it was, and it differs between communities and countries. It is more and more defined as the job of the doctor to do the preventive care, but it's a co-work with nurses, with the education system. There is a debate who is responsible for it, but the aim of staying healthy and preventive care is part of the healthcare system. And today, a huge part of the healthcare system has also to deal with palliative care and dealing with the end of life care. If 500 years ago, the doctor had little to do and mostly gave some remedies and maybe walked with people, and most people, he could help them. They could survive on their own. And then there was the walking with some person through his illness to his death, that usually was very much more quick and was quicker than today. Then today, a new full part of medicine is dealing with end of life care and dealing with chronic disease to the realm of end of life, in between of chronic disability. And all these are actually part of the health system. And that makes a great difference. And every country, and I assume you'll see, part of what we put, how much energy we put in each part of this also differs according to our medical beliefs and to our abilities. And that differs, and that makes a change of how we build our medical systems. Now, the basic for thinking of these things is actually the decision between the continuum, if health is a human right, or is it's a consumer service, a consumer good? Is it a service that we give people and they have to choose? Or is it something that is human right of each of the people? And our approach to the medical system reflects on our choices of resource allocation. I am sure that in every one of your countries, and you come from different countries, you can see it. Some of you are working in the level of the doctor itself and don't look of the whole system, but everyone that has enough years in medicine knows that a lot of what changes, what happens is resource allocation, and that differs according to what we believe in. Now, health is a consumer good. We let the market force to determine the service. And if it's a human right, then the government authorities replace the market force. When I teach students, I start to deal with them, okay, what do you think it is? We will not go into that, but I'm sure that each and every one of you met the different parts of the system throughout your years, between what is really a basic need and what is a commodity, something that maybe some people will get and some will not, depending on the money they have. So when we look at, so if we're talking about it, then a market force system has freedom of choice. It's targeted to wants and aspirations, and the government role is limited. And the classic system is the United States system, that also is not classic at all regarding that. But let's say the purely insurance system works by that. And the social system we're talking more about shared responsibility, general public well-being, targeted to needs of the people. And the government has a very significant role. Now, for market force, I think, well, we grow up here in it's a capitalistic system, but it believes in a shared responsibility. So we do understand both things, and they're on the table. So market force, we believe, is a good thing. It drives many things. We saw it during the corona. There were needs that caused people to do things. At the beginning, it caused also bad things because there were little resources, and then let's say the strong took more. But when it was that the system was well organized, then it was a good thing that the market force started to create workplaces that created different ideas how to gain different tools to fight the corona. The problem with market force is with the system, market force system, is what is needs versus wants. And what if someone can't pay for basic needs? And how do we allocate the resources? And what will the insurer prefer? Usually, it will prefer the rich and the healthy and not the poor and the sick. So that is part of what, let's say, the basic things that I think you should know. Israel is a combined system that works as a social system, and I will describe it in a minute, but has also a competitive and a part of, let's say, market force that works within it. It is not a pure private system, and it's not a pure public system. And we can see, and that changes also the way we think. Because when I was in the United States and I talked with a friend about statins, and I said, well, my insurer in Israel there is first tier, second tier, according to whoever can use the first tier, he doesn't need the more expensive medication. And her automatic reaction, and she was someone who dealt and treated the underserved, and she was very well aware about people's abilities, but her automatic response was, but why cannot I choose? Why can't I choose? That's my basic right to choose if I have the money. So it changes the way of thought. I assume you will see part of that, and you know part of that from your country. Now let's go to a bit of history, as I say. How was the Israel medical system developed? We're talking about over 100 years ago, when the beginning of the Israeli settlement in Israel, the Aliyah from the big the first Aliyah, the second Aliyah that came here, and there was a society that was organizing itself. And the beginning of the medical system was started by the Hadassah organization, which was an NGO. And it started the Hadassah Hospital and the Hadassah nursing schools. It started in 1913, the Well Baby Clinics, that is called Tipat Chalav. If I translate it, it's a drop of milk, but if I give the idea, it's a very known preventive care system, excellent preventive care system for pregnant mothers and babies, and it is part of the reason that up to today, the level of immunizations of baby in Israel is one of the highest in the world. So that was the beginning. And then the British mandate and then the Israeli government have created different things on basis of the British mandate, camps, hospitals. We built the Israeli hospitals. 1911, started the HMOs, independent groups that started a health system. And the first one was the health system for the workers that was developed by German doctors based on the Bismarck system. And eventually this was what was called the Klalit. And up to 1980 in Israel, the 1980s, most of the Israeli population was in this HMO. It is the biggest, it held about 70% of the people. Today it holds about 54% of the citizens, but it was the biggest and still is, but and ensured all the people in all the peripheries. 1920 to 1940, Maccabi Meuchedet and Leumit were founded, and up to 1995, mental health and preventive medicine were provided by the government, and dental health was not included. Okay, what happened in 1995? We had the National Health Insurance Law legislated, and that actually created the system that we have today of an equal for all system, all residents covered. Currently today, you have the right to choose what health provider would you like, one of out of the 4 HMOs. There is a change date 6 times a year, but you're allowed to transfer only once per year. Otherwise, it's a big mess and it does not, let's say, promote health. The funding is by the national insurance payments that include health tax and government payments. And there is additional private insurance allowed by the HMOs, but regulated. By the way, immigrants, Oleh Hadash, are allowed to 6 to 12 months of free membership in the Kupot Cholim. Other than that, every person who works, 5% of his salary goes to the national insurance health tax. If you do not work, there is a minimal amount that you have to pay through Bituach Leumi, and that is what you put into the system. We will see later on in the slideshow that it doesn't cover all, of course. By the way, up to 1995, 98% of the population in Israel was insured by an HMO. So comes the question, why did they need this health law if 98% were insured? So the reason was that the insurance wasn't equal. The Klalit held all the sick and old people and actually was almost bankrupt. And part of what was done by this legislation was that each of one of the HMOs has to accept everyone into their system. And it's equal, and there is an equal health basket that I will describe in a minute. And this actually changed the entire way the system looked. Because beforehand, Meuchedet and Maccabi chose their patients. They had high payment. They could choose who they get in. The Klalit, which was the first one, and is till today is in all the periphery, in all the remote places, could not choose and treated the people who were actually the most expensive. So if we, wait a minute, I'm working. Okay, so let's just a minute say some things about new immigrants. The rights for health coverage for new immigrants. There is no age limitation. There is no health limitation. There is no exclusion for pre-existing illnesses. If I move from one HMO to another, it could be that the supplementary health insurance will not accept me or will say your previous problem is on the other insurance, but there is no such thing with immigrants. There is no exclusion criteria, and there's no waiting period. So that is the basic things that all new immigrants have. Now, what does the health care basket include, and what doesn't it include? So included are doctor visits, blood tests, imaging studies, all studies you need in order to diagnose your diseases, hospital admissions and surgeries, paramedical treatment. As of today, dental care until age 18 or over 75. And as of today, mental health care up to 10, 15 years ago, it was not included in the health basket, and gradually it was moved from private to health basket, that is regarding dental care, and mental care that before that was within the government's responsibility is now within the basket and incorporated into the HMOs. And physically, this enables more people to get mental health care, because part of the reason was to normalize the system within the healthcare system. It's not a shame. It's not something you go to a remote clinic. It's in our basket. And we talk of it as primary care doctors. And we tell people, people know more and more their rights. And it enabled more poor people to get mental health care. There is debate about it, but that's, let's say, third class, not first class, regarding all the debates in the Israeli medical system, which are a lot. What is not included? Dentistry care between age 18 to 75, optometry, and chronic nursing care, which is an important thing, because if someone is unable to take care of himself, there is some part that is within what the bituach laumi, the social insurance, will give you funds to treat. But if you want a certain chronic nursing care, higher level of nursing care, it's not within the regular health basket. This is an issue that is more complicated, and I will elaborate. Okay, supplemental health insurance, which is optional, but every Kupat Cholim, every HMO has it. There is no exclusion criteria for that, but there are 2 or 3 tiers of plans available, and accordingly the cost. And the cost is also not only the tier of a supplementary plan, which is the higher the options, then the higher the pay, but it's according to the patient age. As you age, or as you have basic diseases that are more complicated, if you start the complementary, the supplementary insurance when you're already sick, you pay more. You're not denied of insurance, but you have to pay more. The benefits vary slightly between health funds. Everyone will, if you look at it carefully, you'll see that every health fund has some advantages and some disadvantages. So all in all, it's similar. And what is important for all of you to know, that within 90 days of Aliyah, you have immediate coverage for the supplementary health insurance. Otherwise, if you move between a kupa, if I start today a supplementary health insurance, I have a waiting period, because that is done that if, like now, I get, I hope God that not, but if I get breast cancer and I want a specific medication that is only in the supplemental insurance, and only after I got sick, I said, oh, now let's run and do the insurance, I have a waiting period of 90 days. It won't help me now. It's to encourage people to do these things early. Olim, immigrants, do not have a waiting period if they do it within the first 90 days of Aliyah. So it's important to know that. Okay, what does it include, the supplementary health insurance? As you can see by the triangle, there's the basic HMO, the basic health care, the basic health basket that I want to make it clear that it's one of the widest health baskets in the world, in Europe. We have most of the basic care and more of the basic care, most of the cancer care, and all the operations you need, and all the basic things you need as a medical treatment, you're entitled through the Israeli health basket. The process of bringing something into the health basket in Israel is a thorough and very impressive process, and many drug companies in the world try to bring to Israel their medications at first, because they know that the system is very regulated, and if it's included here, many countries go after us. So we have a wide basic health basket. The supplemental insurance includes subsidized medicines that are not included. Usually you need a pre-approval for that. Second opinions with specialists, operated at private hospitals, or that you can choose your surgeon. And there are discounts on complementary healthcare treatments and discounted dental care treatments. So these are in the second tier of the supplemental insurance. And what it is not included is what we call out-of-basket cancer medication, which is things that were not yet included in the health basket because they don't have enough proof. They're helpful for a short time, for a limited group of people. Some of them, after a few years, do get included after there is more evidence. But people, when they have cancer, want to go to the one tier after another. So one of the things that are not in the supplemental insurance, or maybe today in some of them, but that is something that I always tell my patients, please check for that. What you need is disability and nursing care insurance and out-of-basket cancer medication, more than the regular supplemental insurance, because these are the things that people get bankrupted for, and not for a, let's say, some plastic surgery that they want once in a million. So that is not included in the supplemental health insurance in usual. And that is something that people have a private insurance many times in order to, and there are different insurances also. The law is changing all the time, so I won't go into it. I think you got a lecture about it in a more detailed way. Okay, so let's go back to the medical system in Israel. How does it work regarding government, hospitals? So in general, the government is in charge of the hospitals, the HMOs, and giving treatment to the consumers. Now, finance, actually, the health ministry is in charge of everything, but not for nothing I put the Ministry of Finance in such a big square, because we always say that the Ministry of Health is relatively weak regarding the Ministry of Finance, because if they won't give them the money, it doesn't care what we want to allocate. And regarding regulations, the Ministry of Health has a problem. It's in charge of the HMOs and the hospitals. The HMOs are the four, the Meuchedet, Leumit, Maccabi, and Clalit. But the Ministry of Health is in charge of the hospitals. Some of the hospitals are their hospitals, are government hospitals, some are private, and some belong to the HMOs. So on one hand, they have to give money to the HMO, and on the other hand, they have to give money to the hospitals. But they're in charge, and they get the profit from some of the hospitals, and the HMOs are a different group. So it's a complicated system, very complicated system, but that's what we have, and it works in some way. The hospitals are divided into psychiatric hospitals that belong usually to the Ministry of Health, and the geriatric, that most of them belong to the Ministry of Health, but not all of them. The Clalit also has a geriatric hospital. Most of the hospitals in Israel, Clalit owns most of them. Maccabi has 2 hospitals. Meuchedet today has 1 hospital, and Leumit does not have a hospital of its own, which causes that they send to the other hospitals, and there is a payment agreement between them. Very complicated. Let's not go into it. It's just to show let's say, in a point that the system regarding who regulates what is very complicated, and still works somehow. Where does the money come from? Whenever I work with students, I always tell them, walk the money trail. That's what matters. So the national expenditure on health by financing sector is 23% by health tax, 42% by the government budget, 34% is by private financing, which is quite a lot, what we call out of pocket, and there are some donations. Now, this is a 2022 description. It changes a bit between the years. If we look at the national expenditure per capita, interesting to see that Israel is the lowest regarding national expenditure. If we compare it to similar countries, we are 7.4 and they are 11%. And the average of the OECD is 8.9. Now, we will look in a few minutes at our health benchmarks that are great relatively. So we would say, oh, we're great. We use so little money and we have such great outcomes. But at a certain level, this has a good thing. We're more efficient. We can work with less money and still give good care. But it is not so beautiful, let's say, when the gap is so big between countries that are similar to us regarding abilities and what is used in Israel. Part of the reason of it is that in Israel, as of today, we have the proof of it. A lot of the money goes to security. But regarding the healthcare system, it's held great because there is a great manpower, but there is a shift all the time and we need more good manpower. And that's something you will know now. Regarding, this is another way to see it. How much do you spend in per person in current US dollars? And this is 2017, but the graph looks more or less the same. So we're the lowest. There is the OECD average, and there is similar countries when you look at it. Now, when we look at the changes around the years, then you can see here a graph that shows what happened between 2010 to 2020. Now, remember that 2020 is a Corona year. So the entire world has surged in what its expenses on medicine. So you can see Israel here is colored in blue. So we surged from 7 to 8.3, and we're still so much lower than the other countries and the average OECD. That's the picture. In general, when we always ask, well, is it worthwhile putting in so much money? And how do we measure it? Usually we measure it by longevity. We measure it by how long a person, how much do we put in and how long does a person live? And this is more or less how the graph looks in the world. And Israel is a very good point. It's here. Regarding very high longevity, Italy has dropped since the Corona. But this is Italy, this is Israel. High longevity regarding very little expenditure of money, and that's always the question: how much do we need in order to maximize the use of money? This is Israel, and this is, let's say, the expenditure is here. This is the United States, and their longevity is here, and we are in a very good place regarding longevity, and very low expenditure relative to it. Life expectancy in Japan is the highest in the world. I'm running through it just to a minute. This is the classic curve regarding health-adjusted life expectancy and health spending, and it was put in from the late 1990s, and you can see that it's a logarithm basis, and you can see that health-adjusted life expectancy, as you pour in more money to the system, in general, they put all the countries of the world on it, and you can see that, okay, you spend more money, you get more life expectancy. But if you look into the graph, deeper into the graph, you can see that in poor countries, when you spend more money, the graph is actually rising, and in a general additional spending, relatively large gain in life expectancy, whereas the rich countries, it doesn't really matter. It's tight clustering, and additional spending has a very little gain in life expectancy. In the middle, we say the mid-income countries look fairly consistent in turning dollars into health with a positive correlation, but we have outliers that during the 1990s, we're talking about the high HIV mortality rate countries, which come to show us that we cannot compare each country, as we cannot compare the health expenditure regarding other expenses of countries. If we're talking about Switzerland that does not have war, and we're talking about Israel that just in these days, we're talking about cutting budget from every other office to bring it into the budget to finance the war and all the damages that are happening currently. Okay. That's a bit of a general look. What's the situation is in Israel? In 2019, BCE is a new term. It's not before Common Era. It's before COVID era. So in 2019, before the COVID, Israel was ranked in the top 10 of the healthiest countries in the world. In 2020, it was ranked in the 5 healthiest countries in the world by the Bloomberg ranking. And that was due to the inclusion of COVID-19 resilience rankings. And that is part of what describes the Israeli system, because the reason that we were ranked so high was because we could bring in vaccination so fast, because all the Israeli system is computerized, and the HMO system is very organized. And that was part of the reason that the vaccination that Pfizer wanted to give us the vaccinations, because we could actually follow up and give a lot of data on the reactions to vaccinations. So let's go look before COVID area. Even that, in that time, Israel is in a good place regarding health situation. It's part of it's out of 169 countries, it was in the 10th first regarding health indicators. Now, what's the metrics of excellence? How do you check it? First, the life expectancy in Israel is 82.7. In the OECD, it's 80.5. The vaccination rate, we have 98% of childhood immunization and 68% of flu vaccination for elders. This is before the corona. The corona, we had a very high vaccination rate of COVID, but flu vaccination fell because in general in the world, the trust in the immunization system had fell in general. Infant mortality rate, it's 2.5 to 1,000 live birth. In the OECD is 4.1. Just to give you an example, in Africa, it could be 10 or 8 in different countries or more. And I don't know, you can know about your different countries, what's happening in your countries regarding it. There's also the Israel health system has excellent achievement regarding big data. It's advanced and organized. It helped us, as I told you, get the COVID vaccinations first. We have the ability to analyze health interventions. The technologies are there are other technologies that are enabled by this big data. We have a lot of data in the HMO's database due to, let's say, over 20 years of electronic medical records. Innovations, we have centers that connect tech industry with health system. We have over 6,000 new clinical research at 2021. 2022, we had over 1,600 companies involved in health tech. A lot of money invested into it. During the last year, it was a very bad year in Israel regarding a lot of things, and also regarding health tech and investments in that. But now we're in such a bad time, so we have to wait for after that in order to say a bit more. In general, when we look at the Israeli system, we always say, what would we like beside life expectancy? And that is part of the things we work on in different systems all the time. We are checking quality of life, quality of old age. We have different programs of improving old age. And regarding that, geriatrics, internists, and people from different disciplines are more than needed here, because we know that in all the world, and also here, it's not that attractive of a discipline. People prefer other professions. So the cost of living, the quality of healthcare, the quality of living, all of them are actually measured here when we talk about the quality of life. So we check life expectancy, infant mortality, the number of people that use private insurance and do not rely on the public insurance. And one way it gives us a mark of how strong is the population here, how strong it in understanding what they need, and also in money-wise, can they pay for private insurance? And that is, we have a high level of supplemental insurance in Israel, differs between periphery and center, but it's something that reflects understanding and need and ability to pay for health, at least at a certain level. There is a question of health expenditure versus the GDP, and there is a big talk about it. There is a question of out-of-pocket addition by citizens, which is high in Israel and is in constant talk about it, and accessibility to medical care that is measured and compared all the time. And I can tell you, as I'm part of the management in the health region, in the north region of Clalit Health Services, this is something that we're measured and checked all the time, and we work constantly to improve the healthcare ability. Problems, we're not that great. I think there are different problems. One of the major problems today, as is in many parts of the world, but we see it in Israel, there is not enough doctors per 1,000 citizens. When we compare ourselves to countries around, Germany has much more doctors per 1,000 citizens, and other countries as well, but we're not at the worst part. But there's also disparities in disparities and differences between center and periphery. In the national average is about 3.5 doctors per 1,000 population. But in Tel Aviv, there's 5.1, and in the north, there's 2.3. So maybe it's a bit better now, but because these are not up-to-date numbers, where we don't have, it's all the time, it's a movement of numbers. But in general, that is our main issue. And I must say that the Ministry of Health has launched different programs throughout the last 2-3 years that I'm involved in some of them, of mobilizing good doctors to the north, but more than that, of raising good doctors in the north. And part of all these programs are also programs to focus on immigrants, on doctors that are making aliyah, in order to enable them to adjust to the system as quick as possible, and to fit in to the places they can feel good and do the most. Because that is actually the win-win situation, that all of you, when you come here, will find a place that you'll be happy in, and that you can contribute to the entire system. So we have a problem regarding numbers. So the question is also, what does it mean to all of you as doctors, as new customers in the Israeli system? Each one of you came from a different system.